Okay, I think we can get started. So, hello everyone. My name is Lai Yang, and I'm a graduate student at Washington University in St. Louis. So, welcome to today's Pain Research Forum webinar. We are very excited to have our speakers today to talk about their research on pain and alcohol use. But before we dive into their talks, I just want to mention a few things first. So if you have any questions to the speakers and moderators during the presentation, please submit them using the Q&A function on Zoom. Also, you can use the View option menu at the top of your window to zoom in and out on the shared screen during the presentations. This session is being recorded, and the video will be available later on painresearchforum.org and PRF YouTube channel. Next week, we're hosting a journal club in collaboration with the IASP Acute Pain Seek, where Dr. Dan Argent from University of Cincinnati will present a recent paper on buprenorphine and full agonist opioids for acute postoperative pain management. If you are interested in joining, please register by scanning the QR code on the screen or visit painresearchforum.org. Also, our next webinar will take place on April 23rd, where we will have stellar scientists talking about their latest research on the descending pain modulation. Again, please register by scanning the QR code on the screen or visit painresearchforum.org. So without further delay, I will hand the mic over to the moderator today, Jessica, to introduce herself and today's speakers. Jessica?
Hi, everyone. Thank you so much for attending today. I'm really excited to hear our three speakers talk today. A little background on me. I'm a postdoctoral fellow in the lab of Thomas Kash, who is one of our speakers today, at the University of North Carolina at Chapel Hill, where I am primarily studying how serotonin is involved in alcohol use disorder. I did my PhD at the University of Pennsylvania with Dr. Gregory Corder, studying the neuroscience of affective pain and looking at how affective brain regions change from acute to chronic pain. So these two topics, my predoctoral work and my doctoral work, led me to want to host this webinar. And I'm very honored today to introduce our first speaker. Dr. Emily Zale is an assistant professor in the Department of Psychology at Binghamton University and the director of the Substance Use, Pain, and Health Research Lab. Her translational research program focuses on identifying potentially modifiable mechanisms of bidirectional associations between pain and substance use to inform development of novel integrated psychosocial interventions. Dr. Zale is particularly interested in identifying and working with subpopulations who demonstrate unique pain and substance-related risks and outcomes. So with that, I'll hand things over to Dr. Zale.
Thank you, Jessica. I'm going to go ahead and share my PowerPoint. All right. Do we look good?
Looks great.
Perfect. So I'm really excited to be talking with you all today. The title of my talk is Hidden in Plain Sight, Menstrual Pain as an Understudied Health Disparity in Pain and Alcohol Research. And just a quick overview, we'll spend a couple of minutes just getting on the same page with some background information about menstrual pain and alcohol use. I'm really excited to share a novel study that we just completed in my lab looking at associations between menstrual pain and hazardous drinking. And we'll discuss those findings in terms of where I think they sit in the broader literature and where I'm looking forward to this research going in the future. When I talk about menstrual pain today, I'll be talking about pain that is occurring during menses, so during the menstrual period. And typically, this is experienced as pain that is in the abdomen, sometimes radiates to the back and the thighs, but might also include other pain sites like headache or tender breasts. And what I really want you to know is that very few women make it through their reproductive years without experiencing some level of pain. So although the estimates can vary depending on sampling and time frame, what we know is that up to 90% of females will experience some menstrual pain at some point during their life. And for many women, this can be a recurrent disabling event. We know that about one quarter to one third are absent from work or school at some point because of their menstrual pain. And on average, the pain is rated between about a 5 and a 7 out of 10 on that numerical rating scale. And although it's quite common, it's very normalized and often goes unrecognized, even in medical settings. And although I think menstrual pain is a crisis in its own right, I think it's also of interest to the broader pain community because we know that menstrual pain severity is associated with a greater likelihood of developing other chronic pain conditions. One prospective study found that over 10 years, women with more severe menstrual pain were 41% more likely to develop another chronic pain condition. It's associated with greater laboratory pain reactivity and central sensitization. Prior research looking at menstruation and alcohol use has really focused on hormonal changes during the menstrual cycle. So, looking at things like how changes in estrogen and progesterone might influence things like reward sensitivity, drug seeking behavior, and this occurs in both animal and human models. And we've also looked at how mood changes and negative affect might motivate substance use during menstruation, but there's not yet been study in this field of pain and substance use on pain itself and how that might be motivating substance use during this time. And I think this is important to study because there are known sex disparities in alcohol use. So we know that there are narrowing gaps in prevalence rates for things like alcohol use disorder, and alcohol-related mortality between males and females. And we also know that females experience worse health outcomes at lower levels of consumption. So this is something that I think the alcohol community should be similarly concerned about. This graphic depicts the reciprocal model of pain and substance use, which Joe Dietrich and Lisa Leroux and I published several years ago. And what this is showing is our hypothesis for how the bidirectional associations, the effects of substance use on pain, and then the effects of pain on substance use, might be operating in a way that links them together, increasing the maintenance and progression of both over time. We propose several potential mechanisms of action, and the one that I'm going to focus on today is substance-related outcome expectancies. So I know that we're an interdisciplinary group today. I am a clinical psychologist, but for folks who are not familiar with that term, it is exactly what you think it sounds like. Expectancies mean what do you expect will happen as a result of your behavior. And the literature on expectancies and alcohol is very large and very rich because we know that expectancies motivate behavior and they influence our perception of outcomes. And they are really considered quite key in understanding why people drink. We also know that expectancies for alcohol analgesia are widespread. So they're depicted in pop culture and media, and people may have experience with maybe thinking that they feel a little bit better when they're in pain and they drink. We hear this often from folks with other types of pain conditions. And we know that expectancies for alcohol analgesia in particular are associated with greater alcohol consumption, experiencing worse alcohol consequences, having greater pain intensity, and greater pain-related interference when we look at populations who have other chronic pain conditions and also populations not recruited for pain. You can hold these expectancies regardless of whether you have a long history of pain or drinking. And in fact, we think that these might be part of what's playing a role across that spectrum of both disorders. So for the current study, we recruited 298 females who were currently menstruating for an online survey of menstrual health and substance use. Our average age was about 35 years old and 76% were white. And I do want to note that we did not recruit for menstrual pain. So the only requirement was simply that folks be menstruating regularly. They took computerized measures of a menstrual pain severity numerical rating scale, so 0 to 10. They completed the expectancies for alcohol analgesia measure, which is a 5-item measure that assesses how much analgesia folks think they will receive if they were to drink. The audit is a really widely used measure of hazardous drinking, and we also assessed for other menstrual and pain characteristics that could be confounds. The first result I want to point out is the prevalence of menstrual pain in our sample. So you can see that almost no one reported a 0 on that numerical rating scale. And in fact, the majority, 60%, had moderate pain. This was a 4 to 7 out of 10. And a quarter of the sample had severe pain. This is an 8 to 10 out of 10. Similarly, the prevalence of unhealthy drinking and hazardous alcohol use in our sample is notable. We had 65% who met cutoffs on the audit for unhealthy levels of consumption. And then that hazardous drinking, which was about a third of our sample, takes into account both the levels of consumption and also the consequences that people are experiencing because of that. So we conducted mediation models, and the goal here was to test the association between menstrual pain severity, expectancies for alcohol analgesia, and then our measures of alcohol use. So first, alcohol consumption. And what we found when we tested this mediation model using the process macro for SPSS was that we did indeed have mediation. So menstrual pain severity was associated with greater expectancies for alcohol analgesia, which was then associated with greater alcohol consumption. And the same model held true when we looked at hazardous drinking, menstrual pain severity being associated with expectancies for analgesia and then greater hazardous drinking. And notably in this second model, we no longer had a direct effect of menstrual pain severity on hazardous drinking, suggesting that the expectancies for analgesia were really what was driving this association. So what does this mean for us? Well, I have a couple of key takeaways that I'd like you to have for today. The first is that menstrual pain is extremely common and often overlooked. In the qualitative data that we've collected in our lab, we hear time and time again from women the sense that they must not talk about it, they must push through, they must sort of suck it up. And this sense that if they do try to talk about it with healthcare providers or with trusted others, that they're often dismissed and pushed away. So if you're studying people who are menstruating, you're studying people with menstrual pain. The other thing that I would like to mention is that the associations between menstrual pain and alcohol that we found were unique and occurred above and beyond other pain sources. So in those models that I showed you, we controlled for menstrual characteristics like length of menstruation, heaviness of flow. We also controlled for mood changes so that we were making sure to parse out the contribution of negative affect, which, as I said, had been previously examined in the literature. And we asked folks about other pain. So we controlled for the severity of other pain that people had experienced in the past 3 months, not related to menstruation. So this is something that's unique that's occurring above and beyond these other contributors. Our main finding was that menstrual pain severity was associated with greater alcohol consumption and hazardous drinking, the expectancies for alcohol analgesia. And this is really consistent with a self-medication framework and the canoe model that was proposed by Erin Ferguson, myself, and colleagues. The canoe model really digs into that reciprocal model and specifically proposes the pathway by which people might be motivated to use substances specifically for self-medication. The E in canoe stands for expectancies. So that's one of the reasons that we started here with our interest in analgesia expectancies. One important implication is that our findings show that females expect pain relief, but we don't actually know about the analgesic effects of alcohol on menstrual pain more broadly. And what we do know in the literature is that the effects on laboratory pain often are not clinically meaningful. They're there and they're statistically significant, but they don't reach a level that patients would tell us is meaningful to them. And there's evidence that these effects only occur at both unhealthy levels of drinking and only on that ascending limb of the intoxication curve. So while blood alcohol level is rising. And when we put these things together, it leads us to hypothesize that people seeking analgesic relief might be motivated into unhealthy drinking patterns. So, for example, drinking faster and drinking more to rise that BAC and maintain that higher BAC. And our hypothesis is that over time, as things like tolerance develop, folks might require more and more and then escalate their drinking as a result. So, of course, we need to consider the limitations. This is a cross-sectional study and an internet-based sample. I like to use the analogy of smoke and fire. We're really early on in this work, and so we're just looking to see out, survey the land, can we find some smoke? And I think we did, which means we need to understand a bit more about where the fire is coming from. We did control for pain severity over the past 3 months, but we have limited information on more details about the other pain sources, and we didn't test other candidate mechanisms. That canoe model has other letters, things like catastrophizing and anxiety, which would be interesting to test in the future. And so overall, I think where we're headed next are prospective and real-time data collection. So looking at menstrual pain as a motivator of alcohol use prospectively and as a proximal antecedent in real time. I think that it will be interesting to drill into some of the nuances of the recurrent pain experience and this recurrent intermittent experience that happens in a fashion that might be relatively predictable for many women, versus other types of chronic pain, which, although waxing and waning, might present with sort of more regular occurrence. Um, I'd love to see us test associations at different developmental periods. There's evidence that menstrual pain is greatest earlier towards menarche and then reduces over time. Our sample was 35 years old on average. And so we might be catching people at sort of the tail end of this association. And so understanding what does this look like in adolescence, for example, does this predict something like initiation of alcohol use or trajectories of use into adulthood? And then, of course, we want to test other potential psychosocial mechanisms of pain and alcohol relations, things like catastrophizing and anxiety, as I mentioned. And that takes me to questions.
Great talk, Emily. I just think that this work is so important, and I really applaud you for looking at this issue that I think a lot of pain researchers, myself included, have not included in our models. So I have lots of questions, but first we have one in the chat, and I encourage anyone else to put questions in there. We have about 6 more minutes for questions, so I would love to hear yours. Lanfranco Palesi said, menstrual pain is often associated with migraine, and migraine is a headache that is often triggered by alcohol. Have you controlled for this aspect in your study?
Yeah, that is a fantastic question. I was just at SRNT and talking about nicotine specifically with Andrea Weinberger, who studies migraine and substance use. And that is not something that we have drilled into yet, but something that we really do need to consider. And I think comorbid pain conditions and thinking about how these might all be interrelated are definitely next steps in this area of research.
Okay, so while I wait for other questions to come in through the Q&A, which again, please feel free to ask any questions you have. I was wondering about how placebo plays into this, because you're looking at an expectation of pain relief, and ultimately placebo is expectation of pain relief, whether or not there is a psychoactive substance.
Yeah.
So I'm curious how you think that the placebo effect is playing into this interaction between alcohol use and menstrual pain.
Yeah, there's some really cool data that have come out of Jeff Boissonneau's lab looking at the perceived relief that people say that they get after the fact versus the actual relief as measured by their pain ratings during a laboratory pain task when they had alcohol versus a placebo, and they don't match. So this is sort of that idea that the expectancies that we hold can influence our perception, and in a way that is often reinforcing towards the expectancy. So people believe that alcohol is working better than it objectively is working. And so this is where, as a clinical psychologist, I get really interested and excited about thinking about how we might use that information that we have from these studies in the lab to actually intervene with people and help do things like challenge expectancies to work towards changing behavior.
Okay, so I'm not seeing any other questions right now in the chat, so I'll just ask you one more because I just think this is so fascinating. So one question I had was that you mentioned that there may be some difference in adolescence, but adolescents don't have as much access to alcohol as adults. So, do you expect that it would be difficult to study in adolescence because of this? I mean, certainly in the Bull Center here at UNC, we have plenty of people studying adolescent alcohol use and they are accessing it. But I'm just curious how you've thought about that. And since you're at a university, if you think you'd have a pretty good time getting those like 18, 19-year-olds into a study who are probably experimenting with alcohol.
Yeah, my lab has focused a lot on emerging adults, in part because thinking about the college years and emerging adult years as this period that really sets alcohol trajectories for some folks. We know that the majority of people who develop an alcohol use disorder develop it before age 25. So there's a lot that is happening in that time period. I think that one thing that we would be looking at is something like initiation of use. So, does pain prospectively predict adolescents who go on to initiate or who don't, for example? We do know that in emerging adulthood, pain prospectively predicts alcohol cannabis co-use and cannabis initiation. But when Dr. Callan Williams tried to test that in a nationally representative data set to look at prospective prediction of alcohol use, she was not able to because most people who initiate alcohol use do so in adolescence. So by the time we got to emerging adulthood, 70% of the sample had already tried alcohol at some point. So I think that the metrics that we look at might need to be different. Maybe it's not about frequency and quantity of use. Maybe it's about whether or not they use at all or initiate first use, for example. But I do think that it would be interesting to see if we can see some of these relationships come online early enough.
Yeah, I guess that's where we're very lucky in our preclinical research where we can control the first exposure.
Yeah,
Um,
absolutely.
a final question comes from Jessica Powers, and she said, "This is an interesting and important topic. I am curious if you thought about how factors in the CANU model might relate to the relationship between menstrual pain and drinking."
Yeah, absolutely. So, we honed in on expectancies here. We've got things like catastrophizing and anxiety. We've done some qualitative work in our lab, really kind of trying to get a better understanding of what women do to prepare for menstrual pain when they know that it's coming, and how one of the things we've heard sort of time and time again is this increase in stress and anxiety and a lot of catastrophic thinking related to how bad the pain will be when it comes and catastrophizing in those realms. And so I think it would be really interesting to examine not only what's happening during menstruation, but especially in that run up to menstruation and how catastrophizing and anxiety might be playing a role in that period in particular.
Great. I see that Tom has a question for you, so we'll have him ask that question and then we'll move on to our next speaker.
Hey, Emily, great talk. Really interesting work. You may have said this, but I was curious. Does the the amount of alcohol consumption that individuals consume relate to the menstrual pain severity at all? Or, I mean, I know the focus was sort of looking at
Mhm.
expectations, but I wonder sort of the relationship the other direction as well.
Yeah, the other direction. So I did not test the mediation model in reverse. So we have a bivariate correlation, which we know is not directional. And so that would be something that would be really interesting to look at as well. So thinking about does their heaviness of drinking predict then that they would have worse menstrual pain severity? My goal for a daily diary study and eventual EMA study, ecological momentary assessment, is to look at those real-time covariations to see most likely bidirectional relationships happening sort of together in real time. Yeah.
Okay, thank you so much, Dr. Zale. What a great talk. And I really appreciate you participating in our panel
Thank
today.
you.
Okay, so now we are going to move on to our second speaker. Dr. Lucia Hippolito is a professor at the Institute of Biotechnology and Biomedicine and in the Department of Pharmacy and Pharmaceutical Technology of the University of Valencia in Spain. She is the PI of the Doreal Lab, where their aim is to investigate the effect of pain and other peripheral insults in the mesolimbic system. Dr. Hippolito combines different approaches to promote clinical and preclinical studies with gender perspectives to advance in the design of novel therapies tailored to patients. And with that, I will turn it over and thank you so much for participating.
Thank you very much for the kind invitation. I hope you can hear me well. And I'm gonna go towards sharing my screen, which I think it should be working now. So as I say, I'm very glad to be here, and especially because today I will be presenting the development of a novel nose-to-brain formulation designed to treat pain comorbidities, specifically negative affective states, and hopefully alcohol drinking linked to the presence of pain. Well, as you know, pain is frequently accompanied by negative affective states and other neuropsychiatric comorbidities. And in the chronic pain population, these emotional alterations are very common and also can be associated with increased vulnerability to substance use disorder. This relationship has been demonstrated in several studies, and for example, it has been also shown in our study where the cluster of patients that have presented negative affective state obtain not only higher levels of self-reported pain, but also very high scores in the current opioid misuse measurement. And in fact, this score is way above the threshold of 9, which is the threshold from we can start to suspect the presence of an opioid use disorder. So based on these observations in the clinic, we and others in the field have proposed a framework in which pain alters emotional states and thereby that can be leading to increase in vulnerability to substance use disorder. And one possible mechanism involves the reduced function of the mesolimbic reward system, which is frequently observed in the presence of pain in the clinic population, but also at preclinical level. More specifically, we hypothesize that this dysfunction may arise from the dysregulation in the balance between the mu-opioid receptor signaling and the kappa-opioid receptor signaling within this reward circuit. And therefore, by blocking this increase in the kappa-opioid receptor activity or signaling, could represent a therapeutic strategy to reduce pain-induced negative affective states and consequently decrease this vulnerability to suffer substance use disorders. So to investigate this hypothesis, our laboratory and others have used the complete Freud-adjuvant CFA model of inflammatory pain that I'm sure that you know. And in this model, CFA is injected into the hindpaw. And by using this model combined with other animal models, we examine how inflammatory pain affects negative affective behaviors. First, we assess motivational behavior using sucrose self-administration under a progressive ratio schedule. And as can you observe here, male rats with a CFA inflammatory pain show a decrease in the motivated behavior, indicating this change sensitivity to reward. Interestingly, when we evaluated anxiety-like behavior using the light-dark box paradigm, we observed a different pattern. In this case, female rats were more vulnerable to show a significant reduction in the time that they spent in the light compartment, which is a proxy for the anxiety-like behavior. We then move to alcohol drinking models. There's different alcohol drinking models that can be used, but today I would like to focus specifically on relapse-like drinking behavior. In this paradigm in our laboratory, we found that only CFA-treated female rats show an increase in alcohol intake during the reintroduction phase compared to the baseline before the period of abstinence. What we believe it's particularly interesting is that blocking kappa receptors were preventing these inflammatory pain effects regardless of the model, regardless of the sex. And for example, in the published paper by Nico Masali in Neuron in 2019, the administration of the kappa antagonist, norvinyltorphimin, directly into the nucleus accumbens medial shell restored motivated behaviors, as is shown here. Similarly, in our own experiments, intracumbal administration of NorBNI also prevented anxiety-like behavior in female rats. And moreover, the same treatment reduced the relapse-like behavior that we were observing in the CFA-treated female rats. However, when we attempt to translate this strategy toward a clinically relevant route of administration, we encounter a really important limitation. So when we administer NorBNI systemically, 10 milligrams per kilogram, instead of recovering the behavior, we in fact observe a worsening of the behavioral outcome. As you can see here in these graphs, systemic NorBNI failed to reverse the pain-induced loss of motivated behavior. At this point, we hypothesized that maybe the systemic administration might interfere with nociceptive processing. So to test this possibility, we administered different doses, 4 doses in total of NorBNI to naive rats. And as you can observe in this graph, NorBNI significantly decreased the PO withdrawal threshold, indicating increased nociception. So taking together these results suggest that NorBNI is only effective when it's delivered into the appropriate region, which has been particularly the medial shell of the nucleus accumbens. So therefore, avoiding systemic side effects become crucial, specifically in pain conditions, since, for example, systemic blockade of the peripheral kappa receptors may increase nociception and interfere with endogenous analgesia, and then have no effect in the behaviors that we have recorded. For this reason, we decided, since we are in a pharmaceutical technology department, we decided to develop a novel pharmaceutical dosage form designed to target the brain while controlling drug release and limiting the access of the drug, of the antagonist, to the systemic receptors. To achieve direct brain targeting, we select the nose-to-brain route of administration. This route takes the advantage of the anatomical and physiological properties of the nasal olfactory region, where drugs can reach the brain through the trigeminal or the olfactory nerve pathways, bypassing the blood-brain barrier. At the same time, it's very important to minimize the exposure of NorBNI. And so it was essential to control the release of the drug, promoting the absorption toward the brain while reducing absorption through other routes of administration, such as, for example, the gastrointestinal tract or the nasal mucosa that brings the drug to the blood and then to the systemic level. So to achieve this, we developed nanoliposomes loaded with the kappa antagonist, NorBNI in this case, which they were then dispersed into a thermosensitive hydrogel. This system of the thermosensitive hydrogel allows easy administration because it's liquid at room temperature, but once it's in contact with the nasal cavity, because of the change in temperature, forms a mucoadhesive gel that remains in the respirator in contact with the olfactory mucosa and controls the drug release. So then we prepare liposomes using the thin film hydration method, And we obtain these liposomes that you have here at the picture. And these had around about 200 nanometer size, good zeta potential, and with a good low polydispersion index. What is very important is that we achieve an encapsulation efficacy about the 75% of NORBNI. And this is particularly important because this is allowing us to deliver pharmacologically relevant doses within a small volume that can be administered intranasal. In addition, we develop an in situ thermosensitive gel. And as it is shown here in this graph, you can see how the viscosity of these different prototypes was increasing as we were increasing the temperature. Among these several prototypes, we selected number 5, which showed the most suitable rheological properties. So as a first step, we evaluated whether our nose-to-brain formulation could deliver measurable levels of NORBN into the brain while limiting systemic exposure. As you can see here, and I have to say that these are very preliminary data because we still need to refine a little bit the method, the analytical method. We are just in the limit. The administration of 99 micrograms per kilogram or 128 micrograms per kilogram lead to measurable levels in the brain, not in the cerebellum, and not in other organs. Importantly, our formulation avoided the increased nociception that we were observing when we administer NORBNI systemically. So as you can see here, after administering 4 doses of 200 micrograms per kilogram, the POC withdrawal threshold did not decrease in these naive animals. And so indicates that this formulation is not producing these off-target nociceptive effects associated with the systemic delivery. So once confirmed distribution and safety profile, we performed 2 efficacy experiments. In this first experiment, we performed pharmacological validation. This is very classical pharmacological validation to determine whether our nose-to-brain formulation of NORBNI could block kappa-PO receptor effect by administering then after U54AA, which is an agonist of the kappa-PO receptor. And we evaluate this by measuring dopamine release in the nucleus accumbens, which is the nuclei where we want to have the effect. As shown in this graph, intranasal administration of NORBNI at the dose of 199 micrograms per kilogram was able to block the effect of the U54AA, which is a decrease in the extracellular levels of dopamine in the nucleus accumbens. In a second efficacy experiment, we tested the efficacy of the formulation in the pathophysiological model of pain-induced negative affective state. So for this purpose, we used exactly the same sucrose self-administration paradigm under the progressive ratio of a schedule, which allow us to measure these motivational deficits induced by inflammatory pain. And we tested 2 doses, as you can see here. 128 micrograms per kilogram, which is the higher dose, was able to recover the pain-induced loss in motivated behavior. And this is particularly remarkable because the other systemic administration, the injection of 10 milligrams per kilogram, which is 100 times more, failed to produce this effect. So altogether, our results suggest that the targeted nose-to-brain delivery of kappa antagonists may represent a promising strategy to treat a pain-associated negative effect and vulnerability to addiction. In fact, our formulation showed the targeting to the brain at pharmacological relevant concentrations. We also avoid off-target systemic effects, show high efficacy at 100 times lower dose, and it was effective in pathophysiological model of pain-induced motivational deficits. And finally, I would like to acknowledge people in the lab that did all the work and my collaborations in this project, José Morón Concepción and Ana Malero from the University of Valencia. And I will take any question that you have. Thank you. Sorry.
Thank you so much. What great work. So please feel free, anyone, to type a question in the chat. We have time for 2 or 3 questions. I'll start us off with asking about this method of delivery is going to target all over the brain, right? And well, not the cerebellum as you showed, but I know that you showed at the beginning that the nucleus accumbens shell seems to be this hub for where you need this action to reduce the pain. So I was wondering how you plan to specifically target brain regions so as to not have any off-target effects.
Well, you have reached a very important question. Nowadays, what we obtain is targeting to the brain and not to other organs in the body. But of course, we are targeting for sure different areas in the brain, and kappa-opioid receptors may have other effects, and this is going to be hard to control. That's for sure. Which is very interesting is that because of the anatomic of how anatomy is related to the olfactory nerve. In fact, nucleus accumbens is not that far from, meaning on number of synapses, is not that far from the olfactory nerve, which could be a possibility if we can modify the liposomes so they cannot get destroyed and they can move from neuron to neuron. That's a very hard possibility, but this is one of the things that we could explore. Another particular different technology that we are trying right now is to try to cover these liposomes with antibodies. And so there's the possibility of using a specific A2A, I think it was, receptor antibody, because there's more accumulation of this type of receptor in the nucleus accumbens than in other areas. But still, targeting inside of a specific brain nuclei is going to be really hard. Nowadays, let's say that the limitation that we have is that one.
Great point. I think this is a problem for all of neurosciences. How are we going to specifically target brain regions and not target other ones? But it's great that you have the lack of effects in the periphery. Does anyone else on the panel have a question? If not, I can ask another one. Okay. So I was wondering, obviously, it's not just mechanical pain that we want to target. There's many other modalities of pain. So I was wondering if with this method of delivery, if you've tested any like thermal sensitivity or any other modalities of pain.
Well, that's a great question. We didn't do that yet. We wanted also to try with other models that not with other sensitive model, measuring sensitivity to heat and other models, but also having another model of pain, because as you know, as the audience know, that there's different models of pain that also generates these negative affective states. So the thing is that we didn't test the ability of these nanoparticles to be able to reduce pain sensation by itself. But this would be other thing that we should be trying, because the data that I show you with the nociception is just in the case of knife rats, and that's something that we want to test in the future too.
Okay, thank you so much. Really appreciate you talking today. So we're going to move on to our final speaker, just in the interest of time. We are going to move on to Dr. Thomas Kash, who is a professor and the director of the Bowl Center for Alcohol Studies at the University of North Carolina at Chapel Hill. He earned his bachelor's in chemistry from SUNY College of Environmental Science and Forestry. From there, he earned his PhD at Weill Cornell, working on GABA A receptor structure and function. Then moved to Vanderbilt to postdoc with Dr. Danny Winder with a focus on neurophysiology in the BNST. Dr. Kash started his lab at UNC in 2009 And the Kash Lab focuses on understanding how modulatory signaling can drive pathological behavior related to alcohol use disorder. Okay, so thanks, Tom.
Thanks. Thanks, Jess, for organizing this. Some really exciting talks focusing on pain and alcohol. I am just going to get into it. So, I mean, we've heard a lot about why pain and alcohol are important to study. I approach this, it's a chicken and egg question. Is that we know, and this is data from my lab, we know that engaging inflammatory pain, this is in mice, so it's a little different than Lucia's data. If we give mice CFA, in male mice, we see an increase in alcohol intake. In female mice, we do not. This is just 24-hour continuous access of alcohol. So alcohol and pain can increase alcohol consumption, but also alcohol exposure. So this is 8 weeks of intermittent access to alcohol again, and this is male C57 black 6J mice that can reduce or increase the thermal sensitivity. This is unpublished work, and so it's chicken and egg, and this is partially why animal models are really useful, trying to understand how the mechanisms that drive these two different interactions. And so there's a wealth of brain regions to study for this, trying to focus on alcohol and pain and potential interactions. I'm going to focus on the BNST or bed nucleus of the stria terminalis. So this is a region that receives it's part of the extended amygdala. It receives a dense GABAergic input from the central nucleus. There's a bunch of other glutamate inputs from cortex, from other parts of the amygdala, and then bidirectional connections with the hypothalamus, midbrain, and hindbrain. And this is really how the BNST can coordinate brain-wide changes in activity and thus behavior. We know that this structure plays a role in a lot of important behaviors. Notably, the Manami Lab has done a series of elegant studies over many years highlighting the important role of the BNST in neuropathic pain, induced anxiety and dysphoria. I'd be reticent not to highlight also the Pareca and Neugebauer Lab have done some really elegant work in the central amygdala, which does connect to the BNST. I'm just focusing on BNST today. Work from my lab and others has found that BNST can regulate anxiety, the rewarding properties of alcohol, as well as alcohol consumption itself. And so one of the interesting or fun things about BNST is it's mostly GABA neurons, but there's lots of different peptidergic populations. I'm going to focus on the corticotropin releasing factor population today. And so this is an image from a CRF Cree mouse crossed to an AI9 reporter, just to highlight there's a lot of CRF neurons in the BNST. This is just showing the dorsolateral section in a coronal mouse brain slice. But also we know that in addition to expressing CRF, these mice also express VGAT and can release GABA. And so this is an important thing to hold into your head. They don't just release CRF, they don't just release GABA. There's multiple signals emerging and emanating from these cells. Work from my lab we found over a decade ago that if we use a DREAD-based approach, so this is our approach pioneered by Brian Roth, my colleague here at UNC. It's a designer receptor exclusively activated by a designer drug. We can virally express a GI-coupled DREAD into BNST CRF neurons. And then if we take these mice that are expressing this and we give them the designer drug, which at the time we were using CNO, we can see that this will suppress alcohol consumption. So activating GI signaling can suppress alcohol consumption when we're looking at BNST CRF neurons. And then also what we found is we looked at open field, just sort of a measure of avoidance behavior. We found that suppression or activation of GI signaling in the BNST CRF neurons can lead to an increase in center time. So one might interpret that as an anxiolytic-like effect. And so that is a little tidbit on the alcohol side of things. And when we think about the pain side of things, we know work from the Manami Lab. Here's a 2013 paper where they gave an acute formalin injection. This led to an increase in extracellular CRF assessed via microdialysis. And I would say we did a in vivo imaging study where we measured individual neurons in the BNST, individual CRF neurons. We found following a thermal pain or a thermal stimulus, is a spike in activity of CRF neurons from male mice. A little different in female mice. There's some sex differences here, but it's consistent with the idea that sort of an acute pain insult can drive increases in activity of these cells. but also chronic pain. So this is data from the Manami lab again, showing that in a model of neuropathic pain, what they can do is when they put a CRF1 antagonist in the BNST, they can induce a preference. So it suggests that chronic pain engages ongoing CRFR1 signaling to drive aversion. And then also a more recent paper from the Manami lab just found that CRF neurons in the BNST are hyperexcitable in a model of neuropathic pain. So we have this idea that, with there's these pain states, there's engagement of these neurons, and it looked as if something similar with alcohol. And so the question that we had was, is it the CRF or is it the GABA or some sort of combination that's driving this? And this is maybe a nuanced point, but an important point nonetheless, that when we use these different mouse lines, there's a lot more happening than the tag that we're using. And so we wanted to really understand, what does CRF do? And we know that these cells release GABA. What does GABA release do to these behaviors? We're going to focus on alcohol drinking and some pain responses. And so we have a nice way to block GABA release. We can suppress VGAT in these CRH pre-mice using a VGAT shRNA. And also we can block CRF release by blocking CRF expression in a flock CRH mouse with an AAV-CRE. And we also have a CRH CRISPR that we have some data with. And this is just to show suppression of VGAT with this shRNA works. It can suppress GABA release. We paired this with an optogenetic approach. And also, if we use this viral approach, so AAV-CRE infused into the BNST, we can get a suppression of CRF mRNA in the BNST in males and females. So this is published work from Weilin Yu, former grad student in the lab. And I would say we also have been using this CRISPR approach, but notably, the CRISPR approach doesn't appear to suppress expression quite as well. And this is something to file away. It does, but not quite as much. And I think that might be reflected in some of the behavior I will show you. And so how do these manipulations impact these behaviors? So first, focusing on pain, and I'm gonna focus on the nociceptive responses, in particular thermal pain responses. And so published work from Weilin, we found that if we just delete CRF in males and females, there is a significant increase in the Paul withdrawal latency. So it suggested that deletion of CRF from BNST can reduce thermal pain or thermal sensation in both male and female mice. So this was interesting for us. But one of the things that we wanted to explore was, what about a more, I would say, robust pain state? So again, we shifted back to looking at CFA as to drive an inflammatory pain state. And so for this, we use the CRISPR approach. And I'll say first, in the females, you'll see there's no effect on behavior. So the CFA induced a hyperalgesic response, so the latency was lower, but there was no impact with the CRF CRISPR approach. Whereas in the males, we saw a similar main effect that we saw in the male mice with the CRH CRISPR. We saw a main effect of the CRISPR vector, so they were less sensitive to this thermal sensation, and a bit of a mitigation of the CFA-induced response. So it was a little bit underwhelming, to be fully honest, but some consistency there. So then we wanted to look at the VGAT response. So what about GABA emanating from these cells? And so we used this VGAT vector. And in the male mice, what we again saw was CFA worked as you would think. And there is a main effect of suppressing GABA release here, but there was a really robust effect in the CFA-treated mice of the VGAT vector. So it really mitigated the effect of CFA on this thermal pain sensation in male mice, and nothing at all in the female mice. And again, CFA, showed the predicted hyperalgesic response, but we didn't see any effect of VGAT suppression. And so this again was, I'd say, this was a more convincing and interesting sex difference that we found. And I have some thoughts on it that I can share if we have time. And so just to summarize, we see that CRF appears to be driving some sort of heightened sensitivity to thermal pain. And when we use the CRISPR vector, we get some sex difference effects, probably a threshold-driven effect, where it works more effectively in males. But when we suppress VGAT, which worked equally well in male and female mice, we saw no effect on behavior in female mice with a robust effect in males. And so this got us thinking, what about alcohol drinking? Because one of the ideas is that pain and alcohol, they're sharing some sort of common signaling and circuitry to drive these behaviors. And so what we did, we shifted here from just straight drinking using a home cage approach to an operant self-administration approach, in part so we can assess motivation a little bit more in depth. And very briefly, mice will consume a lot of alcohol in a very brief period of time. This is a slightly sweetened alcohol. We do sucrose controls for everything in separate mice, so we have a lot of confidence with how we're doing this, but they drink a lot really quickly, as shown with this blood alcohol concentration. And so when we knocked down CRF, there was a robust effect on alcohol consumption, which actually was very surprising, in both males and females. And then there was no effect on sucrose. And when we looked at progressive ratio, or how hard they're willing to work to drink, that also was reduced both in males and females. So surprisingly, CRF was able to robustly reduce alcohol consumption. So we turned to the VGAT. And here we saw another interesting thing where there was no effect in the female mice on performance in this operant approach or on the progressive ratio, whereas in the male mice, they actually drank more alcohol earlier. So they sort of escalated their consumption much sooner. And there was a reduction in the sucrose progressive ratio breakpoint. So maybe a hint of some general motivation reduction, and that might have obscured some of the effects we would see with alcohol because it is a sweetened alcohol solution. And so we take that together, so CRF really, from the BNST, really appears to be a driving factor for heavy alcohol consumption in our model in both males and females, whereas VGAT had some effects, but not really many, I would say. And so part of the idea and this taps into something Emily was talking about, is sort of what about the motivations to consume alcohol? And so there is a big idea, a persistent idea in the field, that negative affective states can drive this. So I'm not going to show the data, I'll just tell you, we looked at anxiety for these metrics as well, or anxiety-like behaviors, I apologize. And we saw with CRF deletion, there was absolutely no effect on any measure of anxiety. We did a lot. With the VGAT suppression, there was a change in females. And so it sort of highlight that perhaps in the models we're looking at least, there's not really an anxiety alcohol consumption link, but it seems like there may be some sort of pain alcohol link, something we have to probe further. And I think the key future questions are looking at these systems in alcohol-induced pain states, such as we can get with heavy vapor exposure or heavy long-term drinking, but also looking at pain-induced aversion. So we focused entirely on these nociceptive responses. And the work from Minami and others would suggest that there's probably a key role in the aversive and dysphoric effects. And that's something we need to look into further. And with that, I'll thank the folks in the lab. So this was work started. The drinking work was by Carol Giannessi. Christy Boyd and Summer Jha were working on some of the pain work. Jess is actually following up on some of the pain work, mentoring an undergrad, Max Kaza, who is following up on this. And of course, the funders and all of you for your time, and our collaborators, thank you very much. Time for questions.
Thanks, Tom. So I think we have some time for questions since you told me that you could stay a little bit late. I understand if people have to go. It is 1:01. Thank you so much for agreeing to be part of this webinar. First, a question from somebody I think you might know, Zoe McElligott. She asked, with these CRF neurons, you're not discriminating between interneurons and projection neurons, correct?
Yes, that is correct. So I would say we spent a lot of time developing a method to target projections versus interneurons. And you can use an intersectional approach using a flip-on, Creon flip-off, and using HSV retros into output targets. You can do that, and we did not do that here because it's a very low yield experiment, I'll say. But I do think that would be a very, very interesting question, because I think suppression of GABA release from those interneuron-like neurons is probably very different than what we would see in the projection neurons. It's just really cumbersome to do. You have to do 6 injections, and the yield is low. But good question, Dr. McElligott.
We also have a question from Fred T, who asked, what factors led to the selection of your specific ethanol choice and the 9% concentration?
That's a good question. It ostensibly was based on previous work. that previous work showing that mice will self-administer large amounts at that concentration. I think I mean, basically previous work highlighted that was a concentration where we can get high intake in a relatively brief period of time. And it's a little bit of a game you have to play sometimes with the concentration. We juiced that experiment such that they drank a lot really, really quickly. And I think it does introduce some potential confounds that there's a sweetened component, there was a mild food restriction. So I think a good question that maybe you weren't asking, but I can highlight is sort of trying to understand how some of these effects generalize to other forms of drinking. So, yeah.
And I had a question,
Sure.
which is relevant to my current work, as you know. You mentioned that robust models of alcohol exposure, like the intermittent ethanol exposure, the CIE model, can lead to a development of a chronic pain-like state in the mice. I was wondering if you could just talk a little bit about that and like theorize about what's leading to that and like where exactly is the pain? Is it a central problem? Is it a peripheral problem?
Oh, yeah. I mean, that's a good question. And so I think I'm a little biased here. I tend to think of it as a central issue because it can be corrected with central manipulations. And so there's some really nice work from Tiffany Will's group. So she focused on adolescent alcohol exposure because it can engender longer term effects, more robust effects. But Tiffany found that adolescent alcohol exposure drives a hyperalgesic state that can be reversed with CRFR1 antagonism in the BNST. And I know also Nick Gilpin and others, and I know Jose uh, Maron Concepcion has also done some work with Lucia looking at some alcohol-driven pain phenotypes, looking at central amygdala, BNST connection. So I envision it as we're looking at manipulation centrally that can reverse it, but I don't think that necessarily means that it's not something that originates peripherally as well, because there's definitely been work showing that heavy alcohol exposure can drive changes in peripheral function as well. I'm failing to remember exactly those studies, but I think we focus on the brain because that's where we are interested, but that's not to say there's not a lot happening outside of the brain as well.
Great. Okay, well, thank you so much again to our three panelists and for everyone who attended today. Please check out the Pain Research Forum website so that you can look at upcoming webinars, journal clubs, and our podcast. And yeah, thank you so much.
Everybody, thank you.
Thank you, everybody.